Pathology revealed two also proliferative growths, which were 7 centimeter apart and had moderately differentiated adenocarcinoma. The staging wise, it was T3N0, however, the number of lymph nodes that were resected were just 4. The recommendation is at least 12 lymph nodes need to be resected. In addition to the moderately differentiated adenocarcinoma, there were two sessile polyps, 1.2 centimeter and 1.5 centimeter. So after his surgery, he was treated with adjuvant chemotherapy. Because of the inadequate number of lymph nodes that were resected, at least 12 need to be resected, and this patient had just 4. So 8 cycles of chemotherapy were given that consisted of capecitabine and oxaliplatin. The patient was alright on follow-up for 2 years, and after 2 years he presented again with vomiting for 3 weeks. This vomiting was persistent, and hence an upper GI endoscopy was performed, which showed a growth in the second and third part of duodenum, and the biopsy was suggestive of adenocarcinoma. Imaging wise, it was limited to that, to the duodenum and nowhere else. So again, he was taken up for the second surgery, this time Whipple's pancreatoduodenectomy, and histopathology again revealed poorly differentiated carcinoma, which was staging wise T4N1. Again, adjuvant treatment was given, this time with concurrent chemoradiation, with capecitabine and radiotherapy. This treatment he completed in October 2015. Now, because of synchronous malignancies that he had, this time we performed the expression for mismatch repair proteins, and this was negative for MLH1 and PMS2. The significance of this I'll discuss in the discussion part. Currently, the patient is on follow-up 5 months post-treatment, is asymptomatic. The CECT abdomen and proctoscopy that were done as a part of surveillance were normal. However, the upper GI endoscopy has revealed a small polypoid lesion in jejunum, and the biopsy is suggestive of tubular adenoma with low-grade dysplasia. This report just came last week, and he has been referred again to the gastrointestinal surgery department for resection. Now, this was number 1 case, a 23-year-old male who had 2 malignancies followed by again a polypoid lesion that was suggestive of dysplasia. Case number 2 is a 45-year-old female who presented with pain, abdomen and bleeding per rectum for 3 months. On examination, there was a right hypochondrial mobile lump around 5 into 5 centimeter. Colonoscopy again revealed ulcero-proliferative growth in ascending colon, and CECT was suggestive of mural thickening in 6 centimeter segment of colon in the region of hepatic flexure. In this case also, the family history was significant. This is the patient, and her real brother had colon cancer at the age of 55 years, who took treatment at our own center, and one of the paternal cousin sister also developed colon cancer. Again, the age of onset was 55 years, I'm sorry, and she is also under treatment at ISH. For this patient, the biopsy was suggestive of mucin secreting adenocarcinoma. Again, because of the strong family history, the patient was taken up for subtotal colectomy with ileosigmoid anastomosis. The histopathology revealed extracellular mucin and signet ring cell change along with moderately differentiated carcinoma. 1 of 15 lymph nodes were positive, and hence this was stage 3 colon cancer. Again, the adjuvant treatment was same, 6 months of adjuvant chemotherapy with capecitabine and oxaliplatin. The current status of this patient, the patient is asymptomatic 15 months post-treatment. Now, common things between these 2 cases are strong familial predisposition and some pointers towards Lynch syndrome if we talk about the specific syndromes in case 1 as well as case 2. We'll discuss what are these pointers and what we need to know about familial colorectal cancer. So the points of discussion in today's CCR will be how common is how common is familial colorectal cancer? What are the common syndromes that are associated? Who should be tested for familial predisposition, and how do we test that? What are the implications if a patient is positive for the familial predisposition? So as we all know that the incidence of colorectal varies widely throughout the world, from incidence as low as less than 5 to 6 times more than 32 per 100,000 age standardized rate, maximum incidence being in the Northern America, Europe and Australia. India belongs to a place where the incidence is relatively lower. So if we look at the incidence and mortality worldwide, India lies somewhere here. The incidence is lower as compared to Western population. The worldwide scenario, colorectal is number third cancer in the worldwide and number four cause of cancer-related mortality in males. If you look at the females, it is number two cancer and number four as per the mortality. This is the Globocan data 2012. Coming to the Indian scenario, colorectal stands at number 4 in males and number 3 in females. Of all the cases of colorectal cancer, around 70% of the cases are sporadic and the rest of cases have some familial predisposition, of which 2 to 4% is comprised by Lynch syndrome and less than 1% by familial adenomatous polyposis. Rest 10 to 30% have some familial predisposition for which we don't know what is the genetic basis, and hence they are classified as familial syndrome and hereditary colorectal cancer type X. So risk of colorectal cancer once the patient carries this mutation. In HNPCC mutation, that is Lynch syndrome, it is 70 to 80%, and in familial adenomatous polyposis, it is as high as more than 95%. In the familial risk, where we don't know what is the genetic basis, the relative risk of patients relatives who have one first degree relative with colorectal cancer at any age is 2.3. And if this first degree relative had colorectal cancer before the age of 45 years, the risk goes to as high as 4 times the relative with no family history. And if the patient has more than one first degree relative, again the risk is around 4 times. Now coming to Lynch syndrome, which will be the specific syndrome that we'll talk about today. This comprises 2 to 4% of all colorectal cases, and this is the most well characterized syndrome in the familial colorectal syndrome. The genetic basis is a defect in the mismatch repair, which is caused by, most of it is caused by the genetic mutation in one of the 4 genes, that is MLH1 and MSH2. Both of them comprise around 70% of the mutations. MSH6 and PMS2 also comprise of around 15% each. So what all cancers are predisposed in a patient who is Lynch syndrome? The 2 most common cancers are colorectal cancer and endometrial cancer, with absolute risk as high as 40 to 80% in colorectal cancer and 25 to 60% with endometrium. Apart from these cancers, the whole GI tract is almost the whole of GI tract is predisposed to malignancy, including stomach, hepatobiliary tract and small bowel. The urinary tract and CNS is also predisposed. Now, regarding the colorectal cancers in patients who have Lynch syndrome, there are certain clinical markers which do suggest that the patient may carry Lynch syndrome mutations. Apart from the family history, these tumors are generally right-sided tumors, and on histopathology, these tumors show certain histopathological characteristics like tumor infiltrating lymphocytes, Crohn's-like lymphocytic reaction, mucinous and signet ring differentiation, which was seen in our second patient. The second patient also had the tumor on right side in the hepatic flexure, and medullary growth pattern. Normally, in a person who is not genetically predisposed, for an adenoma to convert into a carcinoma, it will take around 10 to 12 years. And hence the recommendation in general population is to do a colonoscopy every 10 years if the first colonoscopy is normal. However, in patients who have Lynch syndrome, this can occur as fast as 3 years. And hence the recommendation of colonoscopy being repeated every 1 to 3 years. So this has been an observation that these are right-sided. No explanation. So there are certain clinical criteria that have been developed that suggest that the patient may carry Lynch syndrome mutation. One of them is Amsterdam criteria, that is widely used along with Bethesda criteria. These criteria include that the patient has at least 3 relatives with colorectal cancer, and all of the following criteria should be met. Like, one should be first degree relative of the other 2. It should be in 2 successive generations, and one of the relatives should have diagnosis before 50 years of age, where FAP is excluded and tumor should be verified by pathological examination. However, these criteria are quite stringent, and as high as 50% of the cases will be missed if we follow just these criteria. Bethesda criteria is again almost on the same lines to clinically see who all patients can carry Lynch syndrome. However, universal testing for MMR expression, that is all the patients should be tested for MMR expression to exclude Lynch syndrome, has greater sensitivity for identification of Lynch syndrome, and in cost efficacy analysis, it has been proven to be cost effective. And from there, the recommendation has come that all the patients who are less than 70 years should be tested for the mutation. So this is the NCCN guidelines for testing of MMR expression. So all the patients who are less than 70 years and all those who are more than 70 years who meet the clinical criteria should be tested for screening for the Lynch syndrome. Now, how can we test for the MMR expression? There are two ways. One is simple immunohistochemistry for the protein products of the same genes. These are nuclearly expressed. These are MLH1, MSH2, MSH6 and PMS2 as I already described. So in a normal non-Lynch syndrome or non-expressed rather, there will be normal expression of all the four proteins. However, if there is abnormal expression that one of these or more of these are absent on immunohistochemistry, the patient needs to be further tested. So this is a good screening technique for Lynch syndrome. And the other method is microsatellite instability, which is done by PCR and is a more expensive method. So of the IHC and PCR, IHC is easily available, inexpensive and proven to be a little bit more sensitive than PCR. But is IHC sufficient? Like if there is loss of expression of any of these, can we categorize this patient has Lynch syndrome? No. Around 15% of the sporadic patients will have loss of expression of MLH1. So how do we differentiate these from those who carry genetic mutation? We need to check for the hypermethylation of MLH1, and in these cases there is another mutation in BRAF which is present. So in a case who has loss of expression of MLH1 plus minus PMS2, we need to further confirm whether this is sporadic or genetic, and this is done by performing either hypermethylation or BRAF mutation. So if this mutation is negative and there is no hypermethylation, then only we can categorize that this patient has genetic involvement and it is Lynch syndrome, for which we need to find out the specific mutation, which is done by sequencing. So to summarize, after getting the specimen for MSI, the expression is seen on immunohistochemistry. If all the four proteins are expressed, this patient does not carry the Lynch syndrome mutation. However, if these are absent in either combination, we need to do further testing to rule out sporadic cases which can account for as high as 15%, which is done by either hypermethylation testing or BRAF mutation. So apart from colorectal cancer, as so many cancers are predisposed in cases of Lynch syndrome, what all cancers can be tested for MSI? Only endometrial cancer has been validated apart from colorectal cancer to test for MMR expression, and other cancers like pancreatic cancers, CNS tumors and other GI tumors are not validated to be checked by MMR expression. Now what are the implications once the patient has been diagnosed as Lynch syndrome? And there are two implications. One is for the screening of other cancers that the patient may develop, and the other is therapeutic implications specifically in stage 2 colorectal cancer. I'll go one by one. So for the screening, these are the cancers that are predisposed. For colorectal cancer, it is clear that the screening has to be done by colonoscopy to start at the age of 20 to 25 years or 2 to 5 years earlier than the diagnosed colorectal cancer in the family. The frequency is every 1 to 2 years. For endometrial and ovarian cancers, we don't know actually what should be the method of screening and how frequently should it be done. However, few studies suggest that transvaginal sonography and endometrial sampling for endometrial cancer and CA25 for ovarian cancer can be done. However, the age to which we start screening and the frequency is not very clear. For gastric and small bowel cancer, the age at which the screening is recommended is to start as is 30 to 35 years, and the frequency is every 3 to 5 years. For urothelial cancer, urine analysis needs to be performed annually starting at the age of 25 to 30 years. For CNS tumors, a neurological examination needs to be performed annually, again starting at the same age. Now coming to the therapeutic implication for MSI testing in stage 2 colorectal cancer, Actually, in stage 2 colorectal cancer, the role of adjuvant chemotherapy is not clearly defined. Not every patient of stage 2 will benefit from adjuvant chemotherapy. There are certain predictors of patient who may benefit from adjuvant chemotherapy, and these include poorly differentiated tumor, inadequate lymph node sampling, like in the first case, lymphovascular invasion or perineural invasion, obstruction at presentation, and T4 lesions. The chemotherapy recommended is 6 months adjuvant 5-FU or capecitabine plus minus oxaliplatin. Now, the role of MMR testing comes in deciding on this plus minus thing, whether single agent capecitabine or 5-FU will be sufficient or we need to add oxaliplatin. This answer comes by the testing for MMR. In patients who do not express MMR, be it sporadic or genetic, single agent 5-FU or capecitabine is not effective and may be harmful, and hence in these cases oxaliplatin needs to be added. So in those patients who do not express MMR, either of those proteins, 4 proteins to remind you, we need to add oxaliplatin in the adjuvant chemotherapy if it is indicated. For those patients who have intact MMR expression, single agent 5-FU or capecitabine will suffice, and there is no benefit of adding oxaliplatin. Now, just passing comment on the other syndrome that comprise less than 1% of colorectal cancer, that is familial adenomatous polyposis. This comprises less than 1%. The genetic defect is an APC gene located at chromosome 5. There is high penetrance. More than 95% of the patients who carry this mutation will develop colorectal cancer, and this is characterized by early onset as compared to Lynch syndrome, and the screening in these patients is recommended to start at the age of 10 to 12 years. These patients have more than 100 polyps which will be seen on colonoscopy, although there are some variant forms which have more than 10 but less than 100 polyps. So the take home messages from today's CCR would be: familial CRCs comprise 20 to 30% of all cases. This is pretty high as compared to other cancers. Lynch syndrome is the most common and well characterized syndrome of these. This is often overlooked and underdiagnosed because till now the clinical criteria were followed, and as we saw that they will miss around 50% of the cases who carry mutation. Inexpensive and convenient methods of screening are now standardized, which is by immunohistochemistry, although it is not available in-house and still we have to get it outside. And all the patients should be screened for Lynch syndrome by MMR expression in all cases less than 70 years of age, and those who meet the clinical criteria in patients who are more than 70 years of age. Thank you, and I hope I've made you all somewhat familiar with the familial colorectal cancers.
So some questions, and the idea of this presentation is that not that we don't diagnose these cases, we do make the clinical diagnosis, but to substantiate and to confirm the diagnosis, we need to take this help of the private sector. And these tests which are not available in-house, probably immunohistochemistry costs between 8 to 10,000, and the PCR-based tests for the confirmation further cost anything between 150 to 200,000. So that was the whole idea, that we do see these cases.
Lynch syndrome, even for staging endometrial cancer and ovarian cancer, people have suggested at 30 to 35 years. And in fact, some people might want to suggest that prophylactics screening at 35 will be able to.
The simple method of remembering this Lynch syndrome is 3 to 1. The 3 family members, 2 generations, and the one patient younger than the age of 50 years, index case or whatever it may be.
You mentioned this in your paper, that a small subset of Lynch syndrome is presents with sebaceous neoplasms.
They call it
multiple
marker.
or unusual. And you can do exactly the same immunohistochemistry on the skin biopsies.
You
can also
find
get to know whether they have colorectal cancer. Sometimes
sebaceous carcinoma and xanthomas and all.
cystic sebaceous neoplasms, they can be benign sebaceous neoplasms, but they can give you a clue to the presence of Lynch syndrome because of their morphology, and of course it can then be immunohistochemistry. What do you say? PCR will cost 100,000 or 200,000?
This is what available in the market. So this is probably
PCR
a
is not so expensive.
no, sir. There are different techniques and this thing. Usually PCR and then they do next generation sequencing. Probably it's not that common. That's my. I know that HPV DNA will be costing 4,000.
No, sir.
That's
PCR alone will not cost so much unless you are doing sequencing.
so that's what I'm PCR because then you need to go for the confirmation sequencing. So it's cost 150 200,000.
So if there are clinical markers, then we need to find out the exact mutation which will be done by sequencing, so that the same mutation can be tested for in the other family members. So we need to know that exact mutation, and that sequencing cost would be around that.
It has a wide implication for across the specialty, patient, the families.
You can try IgG get ready to do free, but you should give them.
So the first thing would be to perform immunohistochemistry to screen, right? So 4 proteins are there that we need to screen by immunohistochemistry. That is to be performed in all the patients who are practically in India. Average lifespan here is 65 years, and the recommendation is to test in all less than 70 years. So practically all the cases we need to screen for the presence of these mutations, and there is a simple method by which we can do that, and that is by immunohistochemistry. So the whole point was whether this case should.
That is the first item. In India, usually we diagnose about 60,000 new cases of colorectal cancer each year. So 30% makes it's a huge numbers.
Now we are trying to get it routinely, but still, sir, from not in months.
It has
Chemistry is pretty straightforward. Just have to buy the antibody.
That was
Every time, all the day, every day for a large it's just a matter of getting the antibody, right?
so I'll call it a successor if we are able to get in the department. Once already made, I will probably will request her again. All right, thank you very much.
Very good afternoon. Now it's the turn for the Department of Obst and Gynae, and as we have so many medical complications in pregnancy in that continuation, a rare case of aplastic anemia is being presented by the Gynae Unit 1 team, and Dr. Varnit will present the case, and Dr. Vidushi, who ably managed this case, will be reviewing the literature. Dr. Varnit, please.
ये दोबारा लगता है ठीक है थोड़ा सा लाइट करो ठीक है ये पकड़ना
A very good afternoon to everybody. Today I will be presenting a challenging case of pregnancy with aplastic anemia. Our patient was 26-year-old, third gravida, para 2 live one, resident of Faridabad. She was referred to us at 30 weeks gestation with diagnosis of pancytopenia and dilated cardiomyopathy. Coming to the history, it was a spontaneous conception. She, at 7 weeks of period of gestation, she received 2 PRBCs and 2 PRPs in view of severe anemia and thrombocytopenia. Her hemoglobin was 6 grams and platelets were 10,000. Prior to this pregnancy, she never had any episode of epistaxis, mucosal bleeding or dyspnea. She didn't require any transfusion till 28th week period of gestation, and she was prescribed tablet iron and calcium which she took irregularly. Between 20 to 24 weeks of gestation, she received 4 PRBCs and 2 PRPs in view of severe anemia and thrombocytopenia. At 25 weeks POP, she had episodes of epistaxis and gum bleeding which continued off and on till late in the pregnancy. At the same gestation, she also started having chest pain, palpitation and tachycardia. There was no history of edema, orthopnea or tachypnea. Coming to her menstrual history, her previous cycle was regular with average flow. Her last menstrual period was on 25th May 2015, making her expected date of delivery 3rd March 2016. She was married for 11 years, Her first pregnancy was 6 years ago. It was a no, vaginal delivery at home, and the female child is today currently healthy. Her second pregnancy was 3 years ago. In this pregnancy, she had history of dyspnea and generalized edema. She also received 4 PRVCs with no history of epistaxis, gum bleeding, or petechiae. Preterm and cesarean was done at 7.5 months period of gestation due to fetal distress. The child died on day 8 due to prematurity. Third pregnancy was her present pregnancy. At the time of admission, her general condition was fair, vitals were stable, but she was pale with no icterus, sinuses, clubbing, or rashes. Her CNS and respiratory examination were within normal limit. On serious examination, early systolic murmur was heard and she was NYHA class 1. On per-abdominal examination, uterus was 30 week size, relaxed with no scar tenderness, fetal heart sound were present. Coming to her investigation, her hemoglobin at the time of admission was 9.1 grams per day. Her total leukocyte count were 1100, platelets were 19,000. Her peripheral bloods were showed macrocytic normochromic RBCs with mild leukopenia and thrombocytopenia. Her OTPTs were raised. Anomaly scan of the fetus done at 18 weeks of gestation shows no gross anomaly. Due to pancytopenia, her bone marrow aspiration and biopsy was done, which was suggestive of hypocellular bone marrow with overall cellularity of less than 5%, confirming the diagnosis of aplastic anemia. Her echo showed global hypokinesia with mild left ventricle dysfunction with left ventricle ejection fraction of 45 to 50%. It was suggestive of dilated cardiomyopathy. Coming to her management, patient was remained admitted with us till delivery. Weekly gravidogram was maintained. Bi-weekly NST and manning was done to assess the fetal well-being. Antenatal steroid coverage was given for fetal lung maturity. Her pre-anesthetic checkup was done at 35 weeks period gestation as she was planned for elective cesarean at 36 weeks POG in view of her previous preterm LACS and dilated cardiomyopathy. Her complete blood count was repeated almost every 3 to 4 days, and PRPs and PRBCs were transfused to maintain hemoglobin of more than 8 gram and platelet counts of more than 10,000. Her donors were screened for single donor platelet donation. Prophylactic antibiotics were started in view of leukopenia. She was also started on tab isolazine and tab Lasix. In this chart, we can see that she required transfusion almost every week. In total, in antenatal period, she received total of 31 PRPs and 4 PRBCs. As patient was planned for elective LACS on the 2nd of February, but she went into labor a night before, so emergency LACS was done under general anesthesia. She received 19 PRPs per operative. It was a male child of 2,160 grams with APGAR score of 8 and 9 at 1 and 5 minutes. The baby didn't require any nursery care. In post-operative period, she was started on broad-spectrum injectable antibiotics. Tafluconazole was started from day 2, and she received 1 SDP after cesarean on post-op day 4. Barrier nursing was done. Patient was discharged on post-operative day 8 in stable condition. Patient remained asymptomatic till post-op day 19, after which she had multiple episodes of gum bleeding every 4 to 5 days with a low with low platelet counts, for which platelets were transfused. In total, postnatally she received 18 PRPs and 2 PRBCs. On post-op day 21, she had a history of bleeding TB, for which ultrasound pelvis was done, which showed no retained products and no collection. She was started on tab norethiosterone and tab tranexamic acid, TDS, but the bleeding was decreased in amount, but it continues. So last week only we have changed it to 2 tab TDS. Presently, she is continuing on tab fluconazole, cefixime, tab norethistron, isolazine, and tab plus 6. She is counseled for bone marrow transplant, and presently she is following under hematology department. Now I call upon Dr. Devina to discuss about the anesthesia management during cesarean.
Good afternoon, everyone. I'd like to highlight the anesthesia problems in managing a patient, cesarean patient with such comorbidities. When we are planning anesthesia for a cesarean patient, we always have to think of two individuals, and whichever technique we use, it has to suit both the mother and the baby. In addition to this, there were two main concerns. One was low platelet count. It was around 6 to 10,000 with repeated platelet transfusions, and all the international bodies who have given guidelines on regional anesthesia with patients with abnormalities of coagulation say that the platelet count at least has to be 50,000 per cubic millimeter or above in a patient who has a stable platelet count. Even if it is low, it has to be consistent over a period of time, and there are no additional comorbidities in the patient. Only two conditions fall in this group. One is autoimmune thrombocytopenia and the second is gestational thrombocytopenia. For all other cases with unstable patient and a decreasing platelet count, a neuraxial block is recommended only with a platelet count of 1 lakh and above. So, our main choice of regional anesthesia, which majority of patients receive, cannot be used in this patient. The second one was a dilated cardiomyopathy. All anesthetic agents have negative inotropic effect. So we have a double-edged sword here. We do not know which way to go, but still a general anesthesia is a safer option for this patient. And literature search showed aplastic anemia to be associated with dilated cardiomyopathy in pregnant patients as well as young adult males who have had this condition for a long time. And anemia of cardiomyopathy, which is again a dilated cardiomyopathy, was found in literatures. So the goals of anesthesia was to avoid tachycardia and increases in afterload, that is to decrease the not to increase any additional workload on the heart, and to minimize the effect of negative inotropic agents, and to maintain a preload even in the presence of an elevated left ventricular end diastolic pressures. So, so in the anesthesia part, apart from the normal standard monitoring, we have to take an invasive arterial line which will show us beat to beat variability in heart rate. The arterial line was taken as a left radial artery. We had two 16-gauge peripheral IV cannulas for rapid blood transfusion in case of PPH, which these patients are very much predisposed to. We did not want to put an internal jugular vein cannulation CVP for CVP monitoring because of low platelets. However, we had an external jugular vein cannulation done after induction of the patient. Patient already had received 10 platelet-rich plasma by the time, and another 4 was transfused during induction before laryngoscopy because these patients are predisposed to intracranial hemorrhage with the stress of laryngoscopy. Inotropic agents, dobutamine and dopamine were kept ready, and all antiarrhythmic drugs had to be kept on the table. General anesthesia was usual with thiopentone, fentanyl, epicurium, isoflurane, oxygen and night air, and IV morphine for analgesia was given to the mother after delivery of the baby. Reversal and tracheal extubation was uneventful, intraoperative period and postoperative course. In spite of a lot of arrangement, the patient gave us a nice picture. Thank you.
A very good afternoon. I'll be discussing the review of literature in such patients. Now, aplastic anemia, it is a life-threatening hematological disorder that is characterized by absent or markedly diminished hematopoietic precursors in the bone marrow, ultimately leading to peripheral blood pancytopenia. Incidentally, the first case of aplastic anemia was described in a pregnant woman by Arlick et al. Way back in 1888, and the patient died. The incidence is 4 to 6 million in Asia, which is higher than that found in the West. The causes of aplastic anemia includes exposure to chemicals, drugs, radiations, infections. Pregnancy with aplastic anemia is rare. Mortality is more than 20% and up to 60% it has been reported in severe cases of aplastic anemia with pregnancy. Now, pregnancy with aplastic anemia, they can either be pre-existing aplastic anemic cases who were diagnosed before pregnancy and now became pregnant. And the other entity is pregnancy-associated aplastic anemia, which according to Snyder's criteria are identified after the onset of pregnancy with no history of disease or exposure to chemicals or drugs which are known to induce aplasia. Then there are recurrent cases which have exacerbation in each pregnancy and they resolve in the non-pregnant state. The initial literature regarding that is available regarding aplastic anemia with pregnancy, it was suggested that the pre-existing aplastic anemia had better prognosis than the ones who are diagnosed during pregnancy. However, there is a large series of 60 patients published recently in 2016 only and by Lee Bo et al. And in this, they included both the patients, 53.3 patients were diagnosed in pregnancy and 46.7% patients had pre-existing disease. And it was found in this study that the risk of complications, it was not dependent on whether the patient was diagnosed during pregnancy or before pregnancy. And interestingly, even the severity of aplastic anemia, it did not have a bearing on the risk of complications. Rather, it was found that the hemoglobin concentration and the platelet count at the nadir had an association with the occurrence of complications in such patients. Now, coming to etiology, exact etiology is not known regarding pregnancy with aplastic anemia. Pregnancy, through their erythropoietic inhibitory effects of estrogen and placental lactogen, may induce aplastic anemia, and this is supported by the fact that most of the patients they improve post-delivery and relapses in the subsequent pregnancies. However, this resolution after delivery or abortion is present only in 1/3 of the patients. So another view is that the pregnancy may uncover a pre-existing aplastic anemia which becomes overt due to the stress of pregnancy. So whatever the cause, pregnancy itself is quite detrimental to the disease process, which either worsens or becomes overt. So the patients, such patients may present to us with pregnancy with the symptoms of anemia like pallor, easy fatigability, or they may present with skin or mucosal hemorrhages, bleeding from gums, epistaxis or other sites, with low-grade fever or infection anywhere in the body, and rarely because of cerebral bleed they may present to us with sensory motor deficits. Most of the time they present to the obstetrician in second and third trimester, but as early as 6 weeks they have reported in literature. Now, to diagnose aplastic anemia, the requirement is the documentation of hypocellular marrow on bone marrow biopsy, along with the documentation of peripheral blood cytopenia, which requires at least 2 out of the following 3 criteria, and that is hemoglobin less than 10 gram%, absolute neutrophils less than 1500 per cubic millimeter, platelet counts less than 50,000 per cubic millimeter. Now, what complications these pregnancies may have? The reported complications are spontaneous abortion in up to 16%, premature labor in up to 12%, chorioamnionitis, preeclampsia in 15%, premature rupture of membranes, and gestational diabetes. Fetus may have intrauterine growth restriction in 5% because of impaired oxygenation, and even 18 up to 18% cases may have IUD, stillbirth, or neonatal death. In the postpartum period, there can be severe postpartum hemorrhage or puerperal sepsis. Now, coming to the complications that are specific to aplastic anemia, there can be infections, chest infections, and even lung abscess and panophthalmitis has been reported. Then there can be fungal infections. Bleeding can be from gums, there can be epistaxis or hematuria, hematochezia. Even macular hemorrhages have been reported, and they are always at the risk of cerebral hemorrhage. Now, these patients are treated with multiple transfusions, so there is also the risk of platelet refractoriness. However, in all the cases, it was found that about 40% of cases may carry the pregnancy uncomplicated. Cause of mortality in such patients in around 90% cases is life-threatening episodes of hemorrhage or sepsis. Now, this is a last series of 61 patients in which the author found association of severe thrombocytopenia with the pregnancy outcomes. It was found that the patients who had severe thrombocytopenia, that is less than 20,000, they have increased chances of obstetric complications with odds ratio of 6.7 and increased need for bone marrow transplant after delivery, 25% versus 0%, and of course increased episodes of bleeding from gums, etc. So the degree of thrombocytopenia is the most important prognostic factor while in patients presenting with aplastic anemia. Now coming to the treatment entails basically two things. One is the supportive therapy and the specific therapy. Supportive therapy includes repeated blood or platelet transfusions so as to maintain hemoglobin to more than 10.5 gram%, platelet counts to more than 20,000 per cubic millimeter, along with prophylactic antibiotics and antifungals. The specific therapy includes bone marrow transplantation, immunosuppressants by antithymocyte globulin, cyclosporin, anabolic steroids. Though bone marrow transplantation is the most effective therapy, but it is contraindicated in pregnancy because the immunosuppressant agents are embryocidal and teratogenic to the fetus. Regarding antithymocyte globulin and cyclosporin, the current evidence does not favor routine use in pregnancy. So, while manage such patients of plastic anemia who become pregnant, they are to be managed in the tertiary care center involving an obstetrician, hematologist, anesthetist, and neonatologist. The treatment strategy is to be individualized, and apart from regular and ANCs, intensive fetal monitoring is to be done by anesthesia and manning. Now, complete blood count is to be repeated 1 weekly to 4 weekly as shown in this table, and accordingly the transfusions are given so as to maintain the desired level of hemoglobin and platelets. A thing to note here is that if a patient has bleeding from any site, irrespective of the platelet counts, there has to be transfusion, and also if the patient has fever and even if her platelet counts are more than 10,000, but if they are less than 20,000, then again transfusion is indicated. If the neutrophil count is less than 2000 per cubic millimeter, there is role of prophylactic antibiotics, and the most important, patient and the relatives are to be counseled about maintaining asepsis. And if such patients develop infection anywhere, it has to be treated aggressively. Kuhn et al. Noted that while managing these patients, around 53% needed transfusions antenatally and 92% needed intranatally. Though the mainstay of managing pregnant patients remains a supportive treatment, but there has been a mention of using cyclosporin and granulocyte colony stimulating factor during pregnancy. Cyclosporin is a category C drug and is used to decrease the transfusion requirement in severe cases, and GCSF is used in neutropenic infections. No adverse maternal or fetal effect has been noted with their use in second and third trimester. However, such agents are not routinely recommended in managing such patients. Now coming to the timing of delivery. With the advancement of transfusion medicine and antibiotics, most of the patients can be successfully followed till term. And timing of delivery is basically based on the severity of aplastic anemia and presence of any maternal or fetal complications. If aplastic anemia is stable, that is, it is not worsening, and there is no maternal or fetal complication, then such cases may be allowed to go till full term. But if there is any obstetric complication, then the decision to terminate the pregnancy is to be taken according to the degree of severity of that complication. If aplastic anemia worsens, then delivery is indicated after attaining fetal lung maturity. Now, this is in this study by Kuhn et al. Though the patients were limited only 14 cases, but 57 patients had severe aplastic anemia, and in this series, pregnancy was taken till full term in 85.7% patients and was uneventful in 70% with good supportive therapy. And one of the cases of severe aplastic anemia who required 14 PRBCs and 19 single donor platelet transfusion in the antenatal period, even bi-weekly, was also taken till 38 weeks. This is another large series of 60 patients who had 10 patients with severe aplastic anemia. In these 10 patients of aplastic anemia, 40 patients could be taken till term. This is to emphasize that the presence of severe aplastic anemia is not a deterrent to take the pregnancy till term, of course with a good supportive therapy. Now coming to the mode of delivery, cesarean delivery is only for obstetric indication, and usually the induction, when the induction is planned, and at that time if the platelet count is less than 50,000 per cubic millimeter, then platelets are transfused prior to delivery. Now this slide shows the pregnancies after immunosuppressive therapy. This was a very good paper in which the author Ticheliet al. evaluated the outcome of pregnancy and disease course among women who are known case of aplastic anemia and have been treated with immunosuppression. In his series, 36 patients conceived and were included in the study. 61% patients had uneventful pregnancy, 39% had medical complications. There were 34 live births, 2 elective abortions, 1 spontaneous abortion. But to note here is the fact that 19% cases had relapse, which was fatal in 5.5%. And relapses were more common in partial responders than the complete responders. So when such patients who are known case of aplastic anemia and they come before conceiving and they want the counseling, then they should be counseled that pregnancy is possible. There is a risk of relapse, but successful pregnancies are a possibility. And if they don't want to conceive, then sufficient contraceptive options should be explained to them. This is my last slide of presentation. And in this slide, basically after delivery, the patients were followed after delivery for a median of 61 months. And in this study, there was 1 complete responder and 57% had partial response, and no responders were 21%, and 2 patients out of these required bone marrow transplantation at 16 months and 5 years. In last 5 years, apart from the present case presented here, we managed successfully 5 more patients of aplastic anemia. The last one required 79 PRPs. It had severe aplastic anemia, but most of the cases except one could be taken till term. And we contacted with these patients telephonically, and 1 patient is on regular follow-up and is currently on cyclosporin. Now to discuss the postpartum management, the specific therapy of aplastic anemia, when to start, how long to start, what is the cost, I invite Dr. Tulika Seth. Thank you.
So, thank you. That was a very good overview of aplastic anemia and pregnancy. As Dr. Vidushi already said, the very first case of aplastic anemia was described by Paul Ehrlich in a case of a pregnant lady who died. And on autopsy, this is what her bone marrow looked like. It was just a fatty marrow with hardly any hematopoiesis. And the term aplastic anemia was coined by Chauffard back in 1904. When we need to do a diagnosis, it is very important that we get both a bone marrow aspiration and a bone marrow biopsy. The reason why I'm saying this is many times we have patients who come from outside hospitals, they have only a bone marrow aspiration report, and they made a diagnosis of aplastic anemia. You cannot and should not make a diagnosis of aplastic anemia only on an aspiration, because it could be a diluted marrow, and you may actually be dealing with a case of leukemia in which if you did a biopsy you would find a packed marrow. So we need to make sure that we have both of these tests. Once we diagnose that it is aplastic anemia by a bone marrow aspiration and biopsy and the pancytopenia, we then need to do a test to rule out inherited bone marrow failure syndromes. These are diseases that usually happen in pediatrics but may happen in young adults. So if that is negative, then we're dealing with a case of acquired aplastic anemia, which is very common in India. And these are the criteria which are well known to everyone, and we basically differentiate patients into severe, very severe and non-severe depending on their neutrophil counts, because the lower your neutrophil counts are, the more risk of infections you're going to have. The 2 most important treatments for acquired aplastic anemia are bone marrow transplantation and immune suppressive therapy. Patients who are younger and fitter are more likely to benefit from a bone marrow transplant. This can be an HLA matched bone marrow transplant or an unrelated bone marrow transplant. So this is a procedure that we do. It's also done in IRCH, and aplastic anemia is actually the major indication for bone marrow transplant in my department. The second treatment that is very successful in acquired aplastic anemia is immune suppressive therapy,
And in this, we give anti-thymocyte globulin along with cyclosporin, and there's approximately 50 to 60% patients will respond. There is a risk to this treatment, and patients can, after 1 or 2 years of response, can relapse. Some of these patients can also go on to develop myelodysplastic syndrome and AML. This is a therapy that we would recommend more for older patients. There is supportive care also, which is given to a lot of our patients who are unwilling for bone marrow transplant or unwilling for immunosuppressive therapy. The cost of a bone marrow transplant in our center is about 8 to 10 lakhs because we also need ATG and other things for conditioning. Immune suppressive therapy costs about 4 to 6 lakhs depending on the weight of the patient. And so that is one of the reasons why supportive care is given. Though most of the patients that get a bone marrow transplant or immunosuppressive therapy at our center are below poverty line patients because the government is able to fund this. Anabolic steroids are given to a lot of patients, but most female patients do not want to take it because of the side effects. And so cyclosporin is often given to these patients, which can, as a single agent, also have 20 to 30% response. These women are counseled about avoiding pregnancy and using contraception. And as you can see from that report from Dr. Chaudhary of 10 pregnant women with aplastic anemia, they were actually patients who were on therapy. And so the cyclosporin was given before they were pregnant and then was finally stopped when we found that they were pregnant. So the treatment can be immunosuppressive therapy with cyclosporin and ATG. It can give you 50 to 60% response, but there are 40 to 50% patients who will not respond. And these patients then subsequently have to be taken either for bone marrow transplant if they were not willing at the beginning, or then onto supportive care. So that's why it's very important at the beginning to strategize which patient should be the best candidate for transplant, because after immunosuppressive therapy, few patients will then be able to afford a transplant. The response to immunosuppressive therapy can be very good. Patients can be complete responders, that is, they become transfusion independent and their counts can become normal, or they may be partial responders in which their transfusion needs may be decreased, but the counts may not have normalized. Therapy, as already described during pregnancy, is very difficult because most of these drugs are not permitted and only supportive care is allowed, because both bone marrow transplant and immunosuppressive therapy contain drugs that are toxic. But there are problems with supportive care because this is not simply anemia, you actually have pancytopenia, and giving so many transfusions can lead to many reactions like alloimmunization and transfusion reaction. And platelet refractoriness, as already elucidated by Dr. Vidushi, is a very dreaded complication because then these patients will not get a rise to even a single donor unit of platelets. And the only treatment for this is to give HLA matched platelets, which is very difficult. Neutropenia is also very important because these patients are at risk for infections. GCSF, however, is not always very effective because you have to realize it's a stem cell defect. And prolonged GCSF can have complications, though sometimes during a fever episode, we may give GCSF as a trial. So there is a relationship between these two conditions, but there's probably two different types of pregnancy and aplastic anemia. One is directly related to the pregnancy, in which it is caused by the aplastic anemia is caused by pregnancy, and there's a remission after disease and a relapse after if you get a second pregnancy. And there's the other kind, which is probably more common, as in our country, with a high incidence of aplastic anemia and women who succumb to family pressure and want to have children. So in summary, there is probably an etiological link, but and we've already published 10 pregnant cases in which we did not find a link. So there's probably two different diseases, one in which aplastic anemia is due to the pregnancy and the other in which it is just concomitantly present. Thank you.
Thank you, Dr. Tulika, for elaborating the post-delivery details, because after the patient gets delivered, we usually lose track of these patients. And for this CCR only, we try to contact them, and we came to know that they are already taking cyclosporin since last 2 years. I just wanted to know till how long you continue cyclosporins for them? Post-delivery.
See, cyclosporin is basically a supportive care. It is not a definitive therapy. So we would probably continue it if the counts were not normal. transplant, then the cyclosporin is continued for about 1 year post-transplant, and then gradually withdrawn and stopped. That is bone marrow transplant is a definitive therapy. If the patient is given ATG and cyclosporin, then again we continue for about 1 to 2 years post-ATG. Then it's a definitive therapy. But when we give only cyclosporin as a single drug, often we find that when we start tapering the cyclosporin, many of the patients may lose their response, particularly if they don't have a complete response. If they have a partial response, it's very difficult to take.
And when you initiate this treatment, like after this patient which is being discussed, every other week other day she is coming to us with that
She is unwilling for treatment at the moment, so we counsel her. She now is motivated for bone marrow transplant. She was not willing to take any medicines because she said she had side effects with the medicines earlier, and so that's why she's not taking any treatment at the moment.
Sorry for my ignorance of the treatment, but you said you should do aspiration and then you will have biopsy growth. And logically, it seems if you are doing a biopsy, why doing aspiration?
Basically, the morphology of the cells is better seen on the bone marrow aspiration, and the bone marrow biopsy tells you cellularity, fibrosis.
You mean to say both should be done to
Both
reach
should
to
be
the
done.
exact diagnosis?
And in the aspiration, we
I thought when you put the needle into the aspiration, when you put the biopsy needle, the bigger one to cut, then so do you have to put two needles?
one takes the liquid part of the mat and the other takes the solid part of the mat.
Thank you.
When you advise for the termination in these cases, many times they go through and we say now we are terminating. So this is always a problem to us. But we try to continue, we are coming at day 16 weeks, 17 weeks.
An excellent question. If the patient is interested in
It has happened.
definitive therapy, if she wants a definitive treatment, she wants to go for a bone marrow transplant or ATG, or if she does not have supportive care. We unfortunately have a lot of women who don't have a lot of family support, they're not willing to give blood. In those cases, then we give them the option. We never advise for termination. We give them the options and we say that if you want to continue the pregnancy, this is the supportive care, these are the risks, these are the complications. The choice is up to the woman.
Well, I had a patient who in consecutive pregnancies had eclastically, and in between she was all right.
That is very correct, ma'am. So that patient is probably the first
Do they have better prognosis these days?
We have very few patients. I think we have just 2 patients like this.
What is the ultimate prognosis?
The ones who go into remission post delivery, they do
And without bone marrow transplant?
Sorry, I think you can sort it out with the doctor. And I want to know, patient received large number of transfusions. Why cyclosporin was not considered during pregnancy? You made a VIP of the patient by giving so many transfusions. And everybody in pantry, I am sure they will never get so many
So she only got 4 packed RBCs, so that's actually not considered a lot. She got 4 packed RBCs. She did get a lot of PRP, I agree. Cyclosporin we didn't want to give because the baby was viable and it's contraindicated during pregnancy. We had a baby who we thought that we could save, and fortunately we did save. Also, cyclosporin is an immunosuppressant, and we had there was another case, I'm not remembering exactly where, who just before delivery she developed DIC. She was an aplastic anemia.
Yes, and that
We
was
saved
Dr.
the
Deka's
baby,
patient.
but
The
we
baby
lost
had
the mother. So
I would like Dr. Ravi to comment in his teaching on
Yes.
all these
I think
very
we
safe and
just one minute, please.
so if there are so many problems of these platelets, multiple, why not be cyclosporin in third line?
I'm just coming to that. In psoriasis, we use cyclosporin, and I have read in the literature second and third trimester can be given. And I do not know why, this you can discuss with your managing hematologist, why it was not considered. Everybody will not go into DIC or immune suppression. You
A
can
small
try
announcement. I hope all the outstation participants and facilitators have submitted their forms at the first desk. The second thing is that please put in a request for how much ever books or wall charts you bought, the Miss Neha, just put in a request, we give you the number that is. These pictures that we are circulating so that is for your signature. Neutropenia. And it is correct on the list.